Hi, everybody, and thanks for the chance to speak about community-based management of latent TB in Australia as part of the session. I'm Justin Denholm from the Victorian Tuberculosis Program, and really looking forward to talking to you about some of the, practical aspects of rolling out latent TB management, particularly in GP practices across Australia. Over the last few years, I've found myself thinking a lot about 2050 in different ways, and some of the milestones that we've set ourselves between now and TB elimination. That's particularly acute for me as I look at graphs like this for two reasons. One is that we are very much in this first phase on the left here for me. I'm thinking about how it is that we are really serious about optimizing use of our current and existing tools to make the biggest impact that we can on preventing TB. The second reason, of course, though, is that here in 2021, we find ourselves much closer to this period of time in the middle, the 2025 milestones, when we are meant to have achieved all of these things that we said in 2015 that we were aiming for, but in a lot of ways and for a lot of reasons haven't really eventuated. So what I want to talk a little bit about is a kind of roadmap and some first steps that we've been taking around what this would look like in practice. This car going around this track doesn't help you at all, but it took me a remarkable amount of time to program it with my son, so consider it critically important. More importantly, though, has been a series of work that we've tried to do to develop a sustainable and useful model of incorporating latent TB management into Victorian general practices. That started with work that Katie Dale and others led, focusing on estimating the proportion of people living in Australia with latent TB and their distribution based on census data and international TB tuberculin prevalence surveys. We've then coupled that with both active and latent TB data in Victoria to think about some of the regions that are most affected and so might be the most natural places to start investigations. That data, because it's been included detailed census demographics, has enabled some really interesting work around trying to estimate the risk of future reactivation, including developing some models of what kind of optimized care in this setting what the impact of optimized care in this setting might be. Some cost effectiveness work on what the most effective and efficient approaches within that context would be, including treatments and testing and how they might fit into the migration pathway. And then, as a capstone to this work, a series of citizen jury style approaches to working with affected communities, presenting this data to them, and thinking about the acceptability and effectiveness of different approaches, including targeting Victoria-wide or specifically in particular communities or particular geographic groups, to try to help us refine the kinds of strategies that might be most effective and acceptable. Okay. And that's really what has all led us into thinking about general practice base as a significant proportion of where latent TB management can and needs to happen as part of TB elimination. Now, over the last couple of years, we have been doing some pilot work with the Southeastern Melbourne Primary Health Network, which is this area here in red, showing that they have been selected both for their willingness to participate, but also because it's really a critical issue in that context. We had an initial pilot program of 6 GP clinics that we worked with individually around providing training on the diagnosis and management of latent TB, and then a range of supports in terms of access to local specialists and clinical nurse consultants, as well as providing materials and resources for both patients and doctors and practice nurses and local pharmacists, and provision of free actual medications in a disaggregated way into the pharmacies. The GP education programs cover a range of topics. There are a series of videos that we've made that are now available on YouTube and are being updated regularly as we go that cover topics like this, from the gamut of why should people be thinking around latent TB, who is it appropriate to test, what do you do with positive tests, and then actually the administration of medication for latent TB in a community-based setting and some models around that. This is a general model that we started out using. So again, stepping through those same 5 points that the videos on the previous screen covered, but really encouraging awareness of all of the phases and thinking about what aspects can be done safely and effectively in general practice. That has a range of different nuances to it in terms of thinking about who will both be able to be most safely managed and who will get the most benefit from it. And through all of these processes that I've described before, we've really focused on a group of people in the community who are under the age of 35, where active TB can be excluded, and particularly prioritizing those who have been in Australia less than 2 years since migration. At any stage in this process, we also have a series of ways to assess for who does need to be escalated into a tertiary care setting, but looking to find a group of people who overall, the majority of whom will be able to be managed safely in that setting. And as you can see here, the focus in the initial program has been on the use of 6 months of isoniazid for this group of people and selecting those who will be least likely to have side effects from isoniazid, particularly given the age of under 35. There's a series of different ways that we have supported general practitioners in this. That includes written materials, articles that, like this one here on the left, which overviews how these models can be incorporated into general practices in Australia. We've done that in alignment with existing NTAC guidance on latent TB infection management and referred back to there, as well as providing a range of other resources for theoretical and practical basis for latent TB management support. There's also been a lot of patient-level resources developed, particularly things like this. So these 2 images are part of a patient handbook that has information about medication. While these have been translated into a number of different languages, there's also been an emphasis, as you can see here on the left, in terms of having minimal language and easy to understand options, thinking both about ease of translation to different languages, but also varying degrees of literacy as may be appropriate in different contexts, and other support tools that we have to help people with medication adherence and follow up, and also for assisting general practices in being able to monitor adherence to therapy. Now, most of this program has been set up in terms of wanting to provide practical support for GPs. And so most of the evaluation of this first phase has been in terms of qualitative feedback in terms of what works, what the barriers to access are, and we'll come to some of those things in a minute. It's been helpful, I think, for us to do some pre and post program surveys suggesting that GPs who've gone through the program feel like they understand TB more, they feel more confident in latent TB management. And so those kinds of correlative things are helpful. I'll say a little bit more about data in a minute, but looking at what we can get from the existing pilot program, what we found is that a majority of people who accepted a test were willing to be involved in the pathway from here. So starting on the left-hand side, though, there's a group of people who had some basic education provided and were offered a test, but didn't take that up. And looking into some of the reasons for that, some of those are perfectly appropriate. So people who were approached about a test, but in fact had a history of TB or latent TB treatment already, more detailed discussion meant that the treating clinicians determined that they were not someone whose history had put them at risk of TB exposure. For example, people who had grown up in another country which was considered to be low risk for TB, but a range of other reasons that I think are useful for us to reflect on in terms of fear of the results, or thinking about what treatment would involve and anticipating that they wouldn't want to take it, and so declining a test. And in a couple of cases, logistic barriers, potentially like knowledge about TB and latent TB, or lack of availability of some support facilities that are important here. Of the people who are in the database, we found that 65% of those who were tested were positive. Now, you can look at that in a few different ways. Some people look at that and say that that's a very good selection of people who are at risk for having a positive test. Personally, I think this speaks to the fact that we've had a lot of difficulties with establishing databases to track some of these things through the general practice clinics. And that's meant that going forward, we've had to really rethink the way that we want to collect and record data here, particularly in the fact that we're very likely to have not collected a significant amount of data on people who were test negative. And that's something that we really want to strengthen going forward. For people who do get into the pathway, it's useful to see that the considerable majority of them started treatment in a general practice setting, with a couple referred on. Again, some limitations in data in terms of detail on follow-up and adverse effects. Looking back retrospectively through some of the clinic data, one patient developed some abnormal liver function tests while taking isoniazid. That's someone that, from a system point of view, general practitioner got in touch with, happened to be me in that instance, and we stopped that isoniazid and treatment resolved, and then that patient was referred on to successfully complete rifampicin therapy in a tertiary setting. So some significant limitations in terms of this data, but this is the sort of thing that we need to develop more as we go forward beyond that initial pilot. So a few reflections on just the practical aspects of this. The first is that this is feasible. It can be done. There are patients who successfully received latent TB therapy through to completion through this program, but it's pretty labor intensive, and I'll be open about that. If you just look at this pilot project in its own right, nearly $4,000 per completed treatment course. But it's important to recognize that almost all of that cost is not in actually providing care, but in developing a package of resources and models that will be available for ongoing use. It's been very useful to establish some standard pathways based on isoniazid for this program. And now that that's the case, we can now move on to both improving those and thinking about how they can be integrated into better service provision, which might be part of follow-on from migrant screening or into existing communities of practice. Lots of useful ways in which that model can be adapted and developed going forwards. Plenty of practical challenges that we need to face. In the Australian context now, the reality is that many patients will not be, many patients who we would think epidemiologically worth testing will face a cost barrier from the test, whether that's TST or in our case, largely IGRA. And even if medication is provided for free, the dispensing fees and other issues associated with that do present barriers. And so moving forward, we've set up funding so that within our expanded program, those will be covered. there are other practical issues that our GP community of practice continues to work on. So we recognize, across the board for general practices in Australia, there's challenges around providing care solely in a bulk billed way. So we've looked to supplement the way in which GP practices can deliver care in a way which makes it feasible, I guess, in a GP context setting. Some of that has been about providing things like direct patient information videos that can help supplement and make GP clinic visits easier. Some of it's been around models of care, around how frequently people need to be reviewed. Some of it's been around providing checklists so that clinic practice nurses or others can do initial screening. And so I think all of those things have been helpful in terms of developing more sustainable general practice models. And as we've said, pretty significant issues for database entry, and that's certainly something that needs to be developed going forwards. And that's where I think there's a tension for us between wanting to have a system that supports GPs well and doesn't put additional workload barriers in there, but also enables good engagement and good reporting and monitoring of outcomes. And of course, I almost didn't mention COVID, but certainly the latter half of this project was significantly impacted by COVID. And so there's been some pause before we now, just in the last couple of weeks, start to get up and running again with the second phase. So where to from here? The first is that the GP practice network wants to, has now gone on to roll out this program for the next 3 years and to expand that significantly across the network. The plan is for at least another 20 clinics, 9 of whom have signed up over the last couple of weeks to come on board, and will now provide funding for IGRAs or TST training for large clinics that want to do that. We'll cover pharmacy dispensing fees. And we've also recognized that we can use the existing module developed for GPs and start to expand that as new treatment and diagnostic options may come in the future. And as a first foray in that way, we've added a module on the use of rifampicin, thinking about when that's an appropriate option in a general practice setting, and we'll continue to develop that as we go. And finally, that community of practice. So now that there are more GP clinics involved, we also have the opportunities not just for the TB program to be teaching and training, but to be having general practitioners and practice nurses and pharmacists meeting with each other to share their common experience and to continue to develop this organically. Probably a very significant part of this for me is around is linked to the plans for latent TB to become a notifiable disease in the Victorian schedule. Many people will be aware this is something that's been talked about nationally, but at this point, in the first instance, Victoria will plan to list latent TB as a notifiable condition. That's something, because we already have lab-based notification and the considerable majority of latent TB testing is done with IGRAs, we will have both positive and negative. We will have the positive latent TB test results coming directly into the same database that we use now for monitoring contacts and people with active TB. And so it means that we will have a much greater capacity to follow and manage remotely data around patients who are potentially initiated on latent TB therapy. So I think that will be a really important step forward for us, as well as integrating this model programmatically. We also, So when we think about the role that latent TB management may play in general practice clinics, I think we really see a spectrum of activity that different practices may be involved in. So in the first place, most GP clinics already do some form of opportunistic testing. For example, when a healthcare worker student comes to them and asks to be tested and then referred off. So there's usually some point of contact, which will vary a lot based on demographics and context. We also think that there will be increasing pathways that we want to facilitate for that sort of occupational screening, and probably new areas like childcare and aged care where testing may be necessary in future. And it's likely that there will be increasing referrals from migrant screening, offshore latent TB testing. As that aspect develops, it may be that less testing is necessary in a general practice setting because people will already have been tested coming through those programs. Regardless, this is a flexible model that can integrate with those things as we go. As we've seen with rifampicin at the moment, new treatments can be integrated into the same structure that's modified for a local context. So I think lots of capacity for us to continue to develop this as we go. However, we really do need a much better monitoring system, which I think notification and integration of systems will really help us with a lot. Finally, I come back to this graph here. Which, as I say, I've been thinking a lot about 2050, and not just because that's the end horizon for the TB elimination plans, but also because I've been thinking a lot about Australia's climate plans, such as they are, and our pathway towards net zero emissions. This is not my graph. This is something that was on Twitter, suggesting that Australia's current agenda for zero emissions involves doing more or less nothing, and then hoping that at some point in the future, some significant technological fix will get us there very quickly. And in some ways, in the worst examples, I think that's what we've seen a lot of in TB elimination. The hope that we can continue doing what we're doing now until such a time in the future that there's a technological fix. We need new tests, we need new treatment for latent TB. There's a lot of things that we need and are looking for in terms of really critical technological advances. But unless we're serious about doing the hard work now, about making the best use of the existing resources and existing capacities we have, we are going to increasingly struggle as we move into the future, all the more so in a post-COVID world. So I hope that this package of latent TB work in the community is a helpful contribution to that, and we'll really look forward to talking to you more as we go. Thanks.